clinical evaluation, the components. The first component is prosthetic evaluation. And the second one is the surgical evaluation. We like the surgical issues, but we have to start with prosthesis because this topic is about prosthetic-driven procedures. The first evaluation is about prosthetics. We should care about restorative volume, occlusion type, and temporary restoration. And the other parameter, aesthetic evaluation, we have seven components: aesthetic expectations, lip line, the gingival biotype, the shape of restoration, neighborhood bone level, neighborhood restorations, and edentulous width. The last one is surgical evaluation that we call bone volume, anatomical risks, aesthetic risks, and complications. When a patient like this, having a missing place in the left upper side with a pneumatized sinus, and she's suffering, or he is suffering from the lack of teeth and a lack of mastication and a lack of eating properly. But when we see the X-ray, first of all, we have to think about the restorative volume. We have to think about the mesodistal space. We have to think about the restoration width and occlusion. But when we see the X-ray, they don't come into our minds. The first thing comes to our minds are the sinus lifting procedure, because we like to do surgeries. We like to open the flap. We like to create, we like to touch the bone, okay? And after the sinus lift operation, we make the augmentation, and we place 2 healthy or 3 healthy implants. They are healthy, they are in a good angulation, but after that, we finalize the prosthesis, and we remember something. Oh, I wanted to, the patient wanted me to make 2 or 3 crowns, okay? And we passed the ocean, but we are in a bad situation, in a little water drop. What is that? The first implant was located in the wrong place, not the right place. So there is a missing part, and we have to tolerate the missing part with the porcelain material. So that causes food impaction, and you do so many great jobs, you do so many surgeries, but the patient is not happy. Why? Because when he or she eats something, there's food impacting stuck over there, okay? You think that you did a great job, but after that, the patient doesn't like it. And the other thing, this problem happened to me in my clinic, and the patient came to me after finalizing the denture. She told me, "Doctor, you said that it's a difficult job, and first you have to make, you said that you have to make a sinus lift procedure, then place 3 implants, and then you wanted me to place 3 crowns. Why did you make 4 crowns?" Okay, a very good question, because I don't know what to say. It's about the lack of planning. After finalizing everything, you have only one chance to adjust the inner part and the upper part. And it's just like solving a problem, not giving the best option. But in a guided surgery, first of all, you may have to make a good plan, prosthetic-driven plan, and after that, give the best solution, give the best option, not solve the problem, because it's not a problem. You give a present to the patient. So if they were located in good places, then the prosthesis will be maybe 3 porcelains and without no food impaction. Yes, another case. I'm talking about the philosophy. I will come to the subject. Don't worry. I don't know if it is seen here or not. The patient was suffering from the implant, which was located on the 21st area of the upper jaw. And the implant was located very buccally. And there was bleeding. And in the CBCT, after the CBCT and matching the DICOM and STL files, you can easily see that the implant is placed buccally and it must be here. That's why we had very big problems. And I told my patient to take the implant out first. After that, I don't have any chance to place, because I'm not so lucky, I cannot place an implant with a freehand surgery, so we have to make a guide, we have to use a guidance. And after it, I realized that, and I wanted to share the picture with you. This is the new implant, and this is the implant which was placed 5 or 6 years ago. So, what I'm trying to tell, let's start with the reasons of the implant failures. We place the implants very buccally. And when we classify the reasons, it is clearly seen that placing the implants very buccally is around 40.5%. So, that means we don't know where the best place to put. If a patient comes to our clinic, if we think of placing the implant first, then, as I told you before, you don't have any chance to give the best option. You only finalize it with some idiot methods sometimes with the technician, and you have to adjust the upper part with the inner part. So it's wrong. I have so many colleagues, they're good surgeons, and they always tell me, look, doctor, you're going to place only one implant. Do I need to have any guide? Is it very easy? No, it's not about being easy or difficult. And let's try some. We have so many fail cases in our clinic, coming to our clinic. The first one, number 46. To place an implant is very easy for the number 46. But if you place it in the easy case, not in the right direction, not in the right position, then you have a healthy implant, but for nothing. You know the song, money for nothing, implant for nothing. So it is maybe impossible for you to take the implant out, but it is also impossible for you to place a crown on top because it's always decimentating. So you have to renew it again, renew and stick it again. So what do we need? We need healthy implants and healthy crowns at the same time. So we need a little bit guided surgery. When we learn to think prosthetic driven, and when we make the planning first, so we have the chance to give the best option to the patient. Why? Because we can place the implant in the wrong way, in the right way, in the right angulation, and in the right place. So, the philosophy starts with this point. The whole procedure should start from the end. So, we have to start from the end. The philosophy literature, Aristo was the one who mentioned about deduction, and he mentioned about starting from the end. He told those days, those years, if you achieve a goal, you should have a plan. And if you have a plan, you should foresee the final picture first. And then you should study. When Aristo is in our minds, maybe logic is the only word, but make it 2 words, please. Logic and deduction. So, philosophically, starting from the end means exhibiting the final picture, deduction, planning, and to secure all in every point of view. So, we must have a plan before we get started. And the percentages must be like this. 80% professor, prosthodonty, and 20% for surgery. This aphorism is a very good aphorism, and I like this sentence so much. All successful people have a plan, And all unsuccessful people have many excuses. I was tired, I was not good, I quarreled with my wife, and etc. So many things. So if you need a long-term success, predictability and repeatability, nowadays we use 3D plans, 3D designs, and 3D manufacturing. To make the long story short, deduction means planning, and the planning means prosthetic model in prosthetics, prosthodontics. And if you think about, finally, with the surgery, it is guided surgery. And guided surgery, what is guided surgery? The guided surgery is to place the implants on which they will be based for the best fitting prosthetic restoration in the correct position and the most rational emergence angulation by the most comfortable method, and the easiest way of surgical are by a patient-friendly approach. So there are so many scientific papers on this topic, and the first paper I found is the Digital Implant Planning and Guided Implant Surgery Workflow and Reliability. Digital implant planning and guided implant surgery offer many advantages in terms of optimized surgical and prosthetic treatment. Another paper declares that, yes, guided surgery is superior to the freehand surgery, but don't trust him. Don't trust that. It has a little deviation around 1 millimeters. And the other scientific paper classifies the deviations in the coronal place, in the mid place, and the tip of the implant, and it's around 1.6 millimeters. So guided surgery is a tool that can be used to operatively plan the best locations for implants regarding adequate bone and the soft tissue quality and quantity, as well as to smoothly integrate the implants into the prosthetic workflow. We have so many parameters like biologic prosthetic complications, and mucosa-supported guides allow for flapless procedure by not opening the flaps. I had smart friends, elder brothers, and those were the days when a patient comes to the clinic and it is when he decides to do something before everything, he gets an impression and then make a wax up model and then do 2 crowns, 3 crowns, or 4 crowns of bridge. And after that, he understands, he decides to do or not to start anything. Why? Because there are so many parameters. And then, after implants came to our lives, they created some stents, and I respect them. They are, now we don't use this kind of stents, but we have to respect the work and the experience that they spent on this issue. Look, another patient comes to the clinic, and when we see this kind of panoramic X-ray, the surgeons know that it's very easy to place the implants in the right side and the left side with the guide. The bone is very good, but don't forget that this is a 2D view, and that doesn't mean that everything is all right. And it is very easy to place the implants. And after surgery, you feel so great, like an emperor, that everything is okay. And when you get the X-ray, you see that you failed. Implants are healthy, but number 35 and number 44, the implant regions are not good about the angulation. But if you place 4 implants with guided surgery, the implants are healthy, and everything, the location, the angulation are healthy, like you draw a line very sensitively. So it was, I think, I don't know, I don't remember, but it's around 10 years ago, and I would never do this procedure again because it was a very hard job and it took maybe half a day to place the implants. And there was a sinus pneumatized, and the patient has suffering from systemic diseases, and he didn't want me to make big surgeries like sinus lifts, and he doesn't want me to be waited. He doesn't want to wait so much for the final prosthesis. So I tried to place the implants, tilted implants, and that day we don't have any 3D machine. By this 3D machine, it'll be possible for you to do so many things. But I had a 2D machine, a panoramic X-ray, and then what I did, first I dig a hole, I made the osteotomy, and after it, I put a parallel pin, and after that, I realized that I'm in the wrong way, wrong angulation. And I changed my direction, and then placed the implant like only touching the floor, the posterior wall of sinus. Does everything go well all the time? Definitely no. But if you are lucky, again, if you didn't quarrel with your wife or husband, and if the patient opens his mouth very well, everything good, everything looks good, but we never do it again because it's a very, very big mess. So nowadays, we came to the subject. Is there anyone to sleep? No? Okay, that's good. So nowadays, we deal with the computer-aided planning. So we do computer-aided design, and we do computer-aided manufacturing, and the last, we do computer-aided surgery with the surgical guides, with a stopper, with a tube-in-tube system, with a different way of placing the implant, which is a very patient-friendly approach. What are the differences and what had changed from the former implant stents, implant guide stents, and between the new ones? Yes, to make a comparison, we should have some parameters. The parameters are location, angulation, and the depth. And the things that we're going to compare, the freehand surgery and the surgery with some stents from the third-party programs and the guided surgery. And if you can, if you can have a look, you can easily see that the location, angulation, and depth in guided surgery, we're going to have no problem about that. Again, freehand surgery, surgery with stents, and guided surgery, about short chair side, post-op comfort and minimally invasive procedures protocol. And again, we could see that the guided surgery is superior with the all three parameters to the other procedures, protocols. And the last one, which is very important, predictability, repeatability, and long-term success. The guided surgery is superior to the other parameter, to the other protocols. So, guided surgery means accuracy. Guided surgery is prestige. And the brand I'm going to tell you about is the Dentsply Sirona product, which we call M-Guide. I mean, the guided surgery, but we have one letter prefix to the word. So this is what we call M-Guide, and which is the most well-known guides in the world, not in Turkey, not in any other country in the world. It's just like it became like a brand. Using M-Guide is something different. So, again, something Yes, we have so many options about the angulation, the depth, and the right position, a good prosthetics predictability, repeatability, short chair side, and long-term success. But the most important thing, in your private practice, in your private clinics, the patients don't like implants. The patients don't like big surgeries. They only want the dentures, and they want to close their eyes and do everything, but they don't want to hear any words about surgery. When you say surgery, when you tell the stitches, when you tell the sutures, they're afraid. They go back. And they will face so many problems, and you don't have any patience. So that's not good. So in this situation, M-guided surgery, from now I'm going to tell M-guided surgery. M-guided surgery is a very good option. Why? Because in this operation, you may have the chance not to put any stitches. You may have the chance not to open the flap. You can do it without making any incisions. Sometimes you need, sometimes you don't need. It depends on the situation. It depends on the case. It depends on your wish. It depends on your patient's wish. So we have a special kit, special set for placing implants. Normally, when you place an implant, the brand brings you a set, a kit, okay? And when you want to do any guided surgery, they give only 1, 2, 3 apparatus and instruments. It's just like a complementary apparatus, and it's for adapting the one drill to another drill, so it is not easy to use it. But for M-guided surgery, you have a special kit beside the normal kit. You have an implant kit, implant set, but in the M-guide kit, when you want to use M-guide, you should use another set, which is very convenient for you to use. What's it? A specific set for guided surgery only, and it has no adapters or spoons, no closed tray-like shape guide, special unique instruments, the tube-in-tube system, different kinds of drills inside, which is different from the other implant sets. So, an amazing Dr. Daniel Boozer made the latest scientific paper on this subject, and yes, he declared that the guided surgery is superior to the freehand surgery, but what was the aim? The aim was minimizing the free drilling distance plus increasing the length of guided key height. It was very important, and he declares that if you minimize the free drilling distance by making the length of guided key height more, then it'll be more precise to place an implant. So, what makes the difference? The tube-in-tube system. Let me tell you about the tube-in-tube system. You had a drill in the kit, and you had a sleeve on the guide. And when you push the pedal, it is like this. Let me show you again. I'm sorry. This is the drill in MIS M-Guide kit. And this is the sleeve on another tube. Sleeve, it's another tube in M-Guide. And this is the final cut drill part. And when you start, there is a stopper. By this way, you may have the depth control. So it is under control. And for example, think that you want to do the wrong thing, but the guide doesn't let you to do the wrong thing because it was planned in MSoft program, and the sleeves were placed in the best way, in the right way. And if you want to do the wrong thing, the guide doesn't help you. So this is what we call the tube-in-tube system. There are so many guide systems, but the best, I'm not telling you about this brand. I'm telling about the system. The tube-in-tube system is the best option for guide systems. So when we place the guide on top of the tooth and the edentulous part, and when you start drilling, this is the tube and sleeve that what we call sleeve. This is the tube in the drill, and it goes and stops here. And some other guides don't have any special kits. They only, as I mentioned before, they only have some complementary apparatus and some instruments added to the set. And when you want to use the guides, the other guides, then they give you a spoon-like instrument and try to hold this. This is good. With an adapter added to an implant set, it sounds not good because here in the interior side, it is easy to use it, but in the posterior side, how about to work with that? Another thing, is it so easy to perform in the posterior sides? Definitely no. And is there any of us to hold the adapter stable all the time? When you move, the implant is not going in the right way. So that means it's not an entire guided procedure, maybe partially guided procedure. So we recommend it. With a closed tray-like shaped guide, when more anesthesia needed, you have to take the guide out, make the anesthesia, and put the guide again. And this is not the thing we want. So it's another problem. And how about irrigation? When you make the drilling, when you make the osteotomy, so first you should irrigate. I mean, during the operation, you should irrigate the region, the implant region. And how about the proprioception? And the proprioception is very, very, very important feeling for a dentist when we work. We want to feel the pressure where we are, and with a closed tray-like shaped guide, it's almost impossible to feel these comforts. And maybe you have heard about all-on-4 systems, all-on-6 systems. We place so many implants, tilted implants. Yes, we may have some complementary apparatus, but let me ask you a question. Is it fully or partially guided? Yes, guided, but not entirely guided procedure. Because when you move, so you may have the chance to fail. But in the M-guide system, try to do the wrong thing, the system doesn't help you about that point. So, our guide, M-guide is something like that. It has sleeves, and once you fix the guide in the jaw, doesn't move, and it is very easy to make the osteotomy when you follow the protocol and try to do the good things and the correct things with patients. Then you should reach your goal. This is M-guide. And we have some components. As I told you before, the sleeve is the metal part, and the clamps on top of the tooth, and the bridge is combining two parts of the guide. And let's understand how it looks like. The clamp fits the surface of the tooth, and it doesn't move. And the bridge is combining the two parts. By this way, we have the open view, and we have the chance to make the anesthesia when needed and make the irrigation all the time. And when we place the guide on top of the surface, we have to see the clamp harmony. It must touch the surface entirely. So, what is the raw material? The raw material is a mono and oligomer mixture of fluid resin and the formation short chain of carbon molecules transformed to longer chains by the UV light activation and eventually become hardened plastic after these procedures. And it is biocompatible, and it has low viscosity and high mechanical stability, and it's transparent, and it can be sterilized with ethylene oxide and radiation and steam, but we prefer to make disinfection with chlorhexidine. We have a special set for it, as I told you before, and let me introduce you the set. I'm sorry. Okay. So, we have a starting drill here, and we have some pathways. The 6 millimeter, this is the protocol. You should use it one by one. This is the pathway for 10 millimeters and 11.5 and 13 millimeters. If you follow the protocol, it is very easy to place an implant. Let's watch the movie to place an implant. This is the lower jaw. I have a missing teeth for number 30, 36, and 37. No, 35 and 36. And first, we get the CT scan with tomography. And second, we get the impression and create a stone model which will be scanned extraorally. Sometimes we can do intraoral scannings in our clinic, and I do now. With the 3D scanner, we get the STL files and put it on MSoft, and the other files from the patient, from the model, and the wax up the final prosthesis with the wax. This is our goal, and after it we match it, the DICOM and STL data, and then on MSoft we start planning the procedure. We start planning the implants. With the implants, it must be you have the limitless chance to touch the case. You can angulate the implant. You can make the implant go mesial a little bit. Maybe you can make it angulated. It depends on the prosthesis that you look for, that you want to do. And after it, once it is done, we produce it by the help of 3D printer, and then create the design and manufacture it. You know the raw material, you know the sleeves, you know the clamps, you know the bridge, and this is what we call M-Guide. And this is a customized industrial project material. So we write the doctor's name and the patient's name on top. And you see the clamps, you see the bridge, and the procedure. These are the kits. These are the sets for guided implant surgery. So, how does the M-Guide system work? How we create the data? How we match the data? How we do that? First of all, we prepare a patient and get our patient's CT files that you have the machine in your college. But we have some, when taking the CBCT, when we have some rules, and after it, you must contact with us, contact with my friend Pratik, and I don't know if there is an M center here in India. Maybe they're going to arrange it. Maybe I can help them, because I have Turkey about occurring the M center. We have 6 M centers in the world, and you contact with us, and then send the files to us via WeTransfer. It is very easy, and get an appointment for making the plan. And we do the screen sharing on Skype and Zoom, and it is a very, very good appointment, and it's an amazing appointment. And then we finalize our plan. Then it is very easy to click and create the manufacture the item, and then it'll be sent to your clinic. So, basically, maybe you can take this picture because it is very important for you. There are three people, a dentist and the radiologist and the M Center. We have some duties, and the dentist first creates the model by having an impression and, and creates a wax-up scanning by the help of prosthodontic specialists, and then by the help of extraoral scanners, they have the STL files, and you send the patient to the technician, and you get the CBCT with some rules I will tell you later. And with that rules, they create the DICOM data, and it is very easy. Maybe it's around 2 minutes or 2.5 minutes to send the data via V-transfer to the M Center. And when the data comes to the M Center, what we do, we do the data match, and after it is very easy for us to contact with you and create the latest design to produce our industrial item. So once you get the files, once you get your patient, and once he said yes, I want this surgery, and after it, you create, you fulfill a paper like this. This is what we call work order form, which can be filled via internet. And then it is written, your name is written here, and the thing that you want to do, and the things that you want us to be careful about the concave and convex abutments and pontics design. You can fulfill everything here, and once we read this paper, it is very easy for us to understand your wishes. So, again, you can take this picture. The main topic, the summary of this presentation is about matching the two files, which we call DICOM files, coming from the CBCT. It's just like that. You cut the head of the patient, and you take everything out, the only bone, okay? And we divide into parts, and we create numbers. And we send the number, and then in the M Center, we open the bag and put the numbers on top and create the head again, okay? And we work on it. After we finish, we send the head again, and you put the head onto the patient's body. So it's just like that. It's like magic. When you send the DICOM data, we know everything about your patient. In 3D dimensions. The X and Y and Z. And the last thing, the STL file, which I use in my clinic. I make the oral scanning, and I get everything without impression. But it is not so important. You can take an impression. We have so many qualified impression materials. And for this dental college, maybe the dean will help, and you're going to buy an extraoral scanner, and by the help of this machine, you can get the STL data of everything, not about tooth, not only about tooth. You can do whatever you want after getting the extraoral scanning. And the latest thing is having a 3D printer, which is very easy. And after it, the DICOM data and the STL data is going to match, and we found a design after the data match. I learned that this is the machine that you have in your dental college. This is from Dentsply Sirona Orthofos SL. It's one of the best machines in the world, maybe the best one. We have some rules, and I will show you a picture, which is very important, and I want you to take the picture. When you want to make an M-guided surgery, when you send us a DICOM data, please do not get the CBCT normally. We have a different method. And the isolation of the upper and lower jaws is very important. Retraction of soft tissues are very important. Field of view is very important. And immobility is generally very important for getting the CBCT. Take this picture. When a patient comes to your clinic and when you want to make M-guided surgery, please, with this picture, do the same thing to your patient and retract the cheeks and place a piston between the teeth, and please call the patient to get the tongue back a little and then get the CBCT. By this way, it's very easy for us to understand the borders of the bone, and we don't want any mixture with the soft tissue and the hard tissue, and we have to we have to find the border sides of these two tissues. So, DICOM data is over. The second thing, the STL data. How do we do that? We do it by intraoral scanning in our clinics. But you can do intraoral scanning. You can do an impression, a conventional method about getting the impression. And after the impression, you can scan the impression with extraoral scanners, which is not so difficult. And it is, when we make the scanning, I can tell you that it is so calibrated, and it's time-saving. It's a prestige, which is very, very important for the patient's trust on your skills. So, intraoral scanning in my clinic, it is very easy to use the dense place Sirona product, which we call PrimeScan. I don't have PrimeScan, I have Omnicam, because I'm not so young. 6 or 7 years ago, there was no PrimeScan. But the PrimeScan, so many features. Why? Because you can make a very good scanning on the edentulous side. So it is the most important differing properties from the Omnicam. So once you make the intraoral scanning, everything is so easy, and you take the picture and you send it, which is the same as your patient's mouth. It's just like picturizing. And after matching the DICOM data and the STL files, it is just like a game for us. We love to play that game. We love to match the data and try to figure out the implant placement and implant places, and try to find out the parallelism. And if we want to place the implant subcrestally, then we can measure the embedded part by the help of this MSoft program, and the angulation, the parallelism, the subcrestal placement, avoiding the anatomical structures, avoiding the surgeries. It's done by this program, and you can choose the implant type, you can choose the implant width, you can choose the implant length, and you can choose the fixation pins, you can choose everything. Oh, it works from here. Did you get bored? I'm very sorry. Is there anyone who gets bored? No, because they had here, huh? You don't have the chance to be bored, huh? Okay. So, once it's manufactured, the guide, we send you the guide, the industrial item. And with the guide, we send you a checklist. With the checklist, you can check which kit you're going to use, which implant brand. We said yes, we confirmed. The implant type, the implant width, the implant length, everything. And the guide and the kit and the set for everything needed in the surgery. So with this checklist, we send you the latest point of implant screenshot. With the screenshot, you can feel the proprioception at the end of the surgery. When you do it, when you look at the picture, and when you get the X-ray, if it is the same, you're in the right way. So we try to help you to let you understand where you are, where you finish. And this is the thing sticked on the guide box, and by the help of this guide box, you can understand which kit to use. And when you get the guide, first of all, you should sterilize the guide with chlorhexidine at least 10 minutes. And after 10 minutes, you should make a fitting test, if it works or not, if it is stable or not, if it fits or not. If it moves, there's a problem. And what are the important things here? The most important thing is the clamp harmony and bridge sitting and the sleeve mucosa contact that you cannot see here now, and the stability. Once you place the guide, it must not move like this. It must not move like this. A sample. Think that a missing part, we have a missing part in 21, 22, 11, and 12 region. And first, we get the STL file and DICOM data from the model. And then, as I told you before, all the protocol is a prosthetically driven protocol. So we should figure out the last point of the prosthodontics that we are looking for. So we create a wax-up model, and then we get the scanning again for the wax-up model. And at the end, we have the antagonist jaw, and after it, we create a guide and place the implants like Turkish or Indian soldiers, okay? It is almost impossible, especially in the anterior side, which doesn't have any regular shape, you know. It is inclined. You may face so many problems that you think that you are in the bone, but hello, the tip of the implant says hello to you. And by this way, maybe it will take around 6 or 10 minutes to place 4 implants at the same time. In the right position, without opening any flap, with the right angulation, with everything. I mean, in normal surgeries, in the freehand surgeries, you give your best, and after that, you have to know the complications. You have to know how to face the complications, to solve the complications. But here in this protocol, before the surgery, you work a lot. You study a lot, but it's a paperwork. It's on the internet, okay? Getting the data from the STL data and DICOM data, and after it, you just match and you work so hard. This is the main difference. And what do? We made the extraction because they have a periodontal problem, and after it, sorry about the views because it's because of the light. If we close the light, you can see it more clearly, but it's your choice to choose. Then, placing the implants, and after it, if you had the good torque with the primary stability, you can finalize it with PMMA temporary crowns and finish this way. This is temporary. And after waiting for 4 months, the implants are so healthy and the soft tissue is so healthy around the implants and the neck of the implants. 4 months later, you create some, you jump to the final phase, get the impression and make it rehearse, and after it, you finalize it with these crowns. This is a very, very old case. In this point, let's do some questions or a break, I can answer whatever you ask, but I think we can give a 10 minutes or 15 minutes break time. I don't know what to say, I don't know what to do. Half an hour tea break. It's very good for me. It's good to hear it. But, okay, if you have any questions, I'll be very pleased to answer it because I wanted, all the time, I wanted an interactive speeches. Do you have? Yes, please. The microphone, maybe. Just let me give you the microphone. Because maybe the others want to hear you. Yes, my dear colleague is asking a question.
Sir, I have a question related to types of guides. Types of guides. You have shown various 7 kit and N guide, the different types. How to choose them?
Okay, that's a good question. Thank you for asking. It depends on the implant brand type that you wish. For example, for dense-place Sirona, you may use the Lance, you may use 7, you may use C1, you may use V3, and we have different connections. In Lance and 7, you have the hex connection, and the other part, you have the conical connection with V3 and C1. And now there's a new brand called PrimeScan. This is a conical connection. So if it is a hex connection, we will use this kind of set. If it is a regular, if it is a conical connection, you're going to choose the other kit. Perfect.
It's not based on the number of implants.
No.
No.
Perfect question.
Yeah.
It's not based on the number of implants. It's only based about the connection.
Okay.
And yes, we have so many drills. Sometimes you get confused when you look at the drill. Once you understand the philosophy of this set, it is very easy to use it. Why? Because there are no adapters, there are no spoons added to the normal implant kit.
Yeah.
You have a special kit just for this job. So if you start from the start here drill and follow the pathway, for example, this is 11.5, and you do first, second, and third, then it is over in 3 or 4 minutes.
Okay. Thank you, sir.
I thank you for the question. And another question. So many handsome guys here, this row.
Good afternoon, sir.
I'm known as a brown man in my country, and I feel like I'm home. Yes.
Sir, my question is related to some clinical, sir, what is the cost of that M guide, and where it is in India where we are making this, and how much time it requires if we give an impression?
Perfect.
And my second question is, are these M guides useful
Just answer, please.
Okay,
let me answer the
yes.
first because I'm an old man, and it's very easy for me to forget it. Sometimes for the last 3 days, for the last 3 years, I look in 1 second and go and want to write it. What was it? Again, turn, look, 43, okay? 42, 43. So let's answer it, okay? The first thing, I don't know anything about the price because now they are arranging the system to settle, okay? They know what to do because the economical policies, the economic politics are different from from country to country. So I can say nothing about this. And once the M Center is over, once M Center is settled in the country, when you send the data digitally, it takes 4 or 5 days in Turkey. If you send a stone model, which is a little bit risky, but we still do the same thing in our country, and it takes around 7 or 8 days. Look, if you want to do a good job, the days are not so important. So sometimes, I will show you a case, so many cases. Sometimes a patient comes to you and he wants everything immediately. Where were you for the last 20 years? Okay? So after 20 years, you want me to solve the problem in 6 days? Okay, thank you. I'm not a magician. So when you start saying yes to the patient's wish all the time, that's the day that you start failing. If it is okay, if it is a normal wish, then you do your best and never give any promise, because during the operation you may face so many problems. I'm doing this job for 23 years. Whenever I say, yes, it's okay, I'm a little bit good, and tomorrow I fail. So 6 days, 7 days, depends on the cargo systems, okay? Another question, the other question. You forget it? Forget it, you forget it.
No, sir, I'm 28 still.
Now he creates the new question, okay?
No,
You
sir.
forget it.
Sir,
This is my
another.
tactic. Pratik, where is he? Okay, no. Okay. When I say tactic, remember Pratik. The pratik is the same meaning. I know, pratik. It's very pratik. We can do it in a good way and a pratik way. Is that the same? Like that. But you're so handsome. No problem. Okay.
Sir, my another question was.
So what is your name? I'm sorry.
Sir, myself, Dr. Akash Bakal.
Doctor?
Akash.
Agash.
Yes, sir.
Perfect. So you're a doctor and you
Yes,
finished the internship?
No, sir, I am postgraduate student.
Postgraduate.
Yes, sir. I'm
Perfect.
studying. Sir,
Nice
my
to meet
question was, is there any changes needed for zygomatic implants or one-piece implant if you are placing, or the procedure is same only?
Okay. And it's an advanced surgery. The zygomatic implants are good things. When you don't have anything to do in the maxilla, you place zygomatic implants, but it's not the M-Guides procedures issue. So I can say nothing about this. Zygomatic implants are something different, okay? And if you're in that situation, you should follow the advanced surgical skills, procedures, but not with M-Guide. I'm sorry. It cannot do everything. Another question from this side, 2-0. Yes, perfect. You please, 2-0. Any question? Let's create a question. Ask me. Oh, 3-0. I'm sorry. Okay. Okay, I hear you now. The light must be off.
Whether the guide is fully at the level of the mucosa, it is guided. It's for the initial pilot drill, fully guided.
Yes, fully, totally guided.
Totally guided. We need not remove each layer like that. After the pilot drill, we need not remove the
No.
first layer.
First of all, we get I will show you, but thank you for, again, questioning me about this. Once you get the guide, once you get the sterilization procedure, when you finish it, when you put it in the mouth, if it is not a too retained guide, then you make the fixation first.
Okay.
When you fixate the guide to the upper jaw or the lower jaw, then everything is fully guided. The most important thing, where to fix. Does it allow you to be fixed in only one direction or not? Yes. The guide system says yes to this question.
Okay. Like I have seen the guide, you have shown it, the clamps are on the tooth.
Mm-hmm.
What about the edentulous situation?
What about the edentulous situation? It's perfect. So we have some reference points, and I will show you in the other part. But let me show you, I hope I bring, because tomorrow and for 3 days more, I'll be in India tonight to Pune, and it is different, Pune and Pune. And there will be a workshop. And there will be some postgraduate doctors there, and they supplied everything, I'm sure. Hope so. Maybe. But I bring something just for you, because I was not sure about having this item for this. I can give it to you and you can have a look, and then please give it to me because I need one. I only have one. Sir, this is the model, and this is the guide. You have the bridge, and you have the sleeve. I'm sorry. The real guy. I'm sorry. So how, okay, how can you do that? So what do you want me to do? Aha, the capture, okay. So, capture of what? By how? Show me, okay. So this is the guide. It is an industrial item. And we have sleeves, we have clamps. And once we put it, it is a tooth-retained guide. Then it doesn't move. Then it is very easy. Yes, doctor. It's very easy to put the drill inside. And the second rule, you must close your eyes, okay? Close your eyes and pedal, and it's over, okay? You don't need to open your eyes. Yes, but please open, okay? Don't close, okay? One question, the microphone, please. You can talk like this. Microphone is coming. No? Sorry, doctor.
The drilling size which is given in that is for the final drill. So that size which is there.
No. You failed.
It's for
We
pilot
have a tube system.
drill. Okay.
And look, it's very good. Thank you for asking it. But let me show you. Let me show you. It's one of the great parts. Yes. You see this picture, and every drill has the same part, the same tube, in the same size, in the same kit. This part, the same. The final cut part differs from drill to drill. So when passing through this sleeve, everything is the same. A unique procedure, similar procedure. Got it? Perfect. Okay. Any question? Any question? You want me to sing? I can. But I don't know any song from Indian song. Sorry, can you please open it?
So the tube which is being used to drill, so does it depend on the thickness of the soft tissue? Like if I have to place an implant of 10 suppose, and I have a thickness of the soft tissue of 2 so what will we be doing with this?
Perfect. But we arrange everything on M-Soft. We have the chance to locate the sleeve up if the thickness is big. For example, the soft tissue is 4 millimeters, okay? And if you embed the sleeve in 5 millimeters, so that means there will be a contact and what we call stasis, on the white side on gingiva. Then it'll make it a little bit resilience, okay? So it'll send you in the wrong place. But it's around 1 and 1.3 millimeters as discussed in the scientific papers. Not a big difference, not a big fail, but it's around 1.3 to 1.6 millimeters. So you have the chance to locate the sleeve a little bit up. And we have 2 options for the sleeve, the short one and the long one. Okay, if it is long, then you may face some problems. Sometimes there are some irregularities on top of the bone. So we need to make bone reduction. I will show it later. Okay?
This is a
They don't hear.
yes, sir.
Okay? Yes.
So this is not this is the procedure where the flap is being not raised. We are doing directly
Flap is not
being raised.
raised. Okay.
we are doing it mucosal, direct, punch.
Yes,
Yes.
this is what we call excision, punch-out excision. I will show you. I will show in the presentation, but it's up to you. It depends on your wish. For example, if you are a periodontologist and you don't want to lose any attached gingiva, and then you open, you place the implant, and close it again. It depends on your wish. Sometimes we make the excision and punch out the gingiva and finish everything and put the excised part again and then let the patient go. So it depends on your wish. Okay, never change. It never changes. But prior to surgery, please let us know that you're going to make an open flap surgery. At that time, when it is not, it is a flapless surgery, and then we can place the sleeve as we can imagine, as we can see on the screen. But look, if you open a flap, then we will prefer to put a longer sleeve. Why? Because we want to minimize the free drilling distance. Okay? Thank you for questioning. Oh, thank you. Any question? Yes? 3-0. Is it spicy? Tea with milk? Ginger? The same one? Yeah. The same one. Same one.
We all be having now a tea break, and the next lecture will start in 15 minutes.
Photography is our job now. And sometimes I took pictures and took another one and another one 10 times for one picture. And then when I go there, I see the lights. I hate it. Sorry. Yes, there is a small movie for you, for all of us to understand the protocol, the procedure, without the voice. Watch it carefully. If you want to place 2 implants for 4.2 and 11.5, this is the box, and this is the kits. These are the kits, I'm sorry. One is a drill kit, one is a tool kit, and in tool kit we have some supplementary instruments, the template, and the USB. Yes, this is the model, and we place the template. Okay, watch the seating, please. And it must touch the tooth surface entirely. This is the punch-out excision for 25 RPMs with irrigation. 1 and 2. It's over. And then we take the guide out. Why? In order to make the excision and punching the soft tissue out. And now we're face to face to the bone. And now I'm gonna apply the guide again and put it on put it on the model. Now this is the bone milling instrument. You know, sometimes we have some irregularities on top of the bone surface, and we have to flatten, we have to make it smooth. We have to gain a smooth surface to place an implant, and this is the first drill with 6 millimeters, and it's over. And again, we have to follow the protocol. And the second drill, we follow this pathway, the 6, 8, 10, 11.5. And before the last one, the last drill, we do the osteotomy with 300 RPMs, with irrigation, please, with a cold saline solution. What else? This is the final drill, I think. I don't remember, but is it the final drill? Once we finish the osteotomy, no, this is the final drill, I'm sorry. Once we finish the osteotomy, we're going to take the M guide out, and no, I'm sorry. We will place the implant inside the sleeve, and then everything will be over. And think that you are performing a freehand surgery first, and after the anesthesia, you have to make a full thickness flap. You have to raise a full thickness flap, and then flatten the surface, and then place it, and stitches, and telling so many things after the surgery. You get the implant. It is very easy to handle it. So normally, I place it with angle drawer, with a piece at the same time. But first, I use the machine, the angle drawer, and after it, maybe for the last 2 or 2.5 turns, I use the handpiece ratchet, torque ratchet. And place the implant. The tube-in-tube system never lets any implant to go in a wrong direction. And now, the end is near, so I face, I'm sorry, the final curtain. No, not the final curtain. So we're finished. After it, we have 2 options. For example, you place the implant with a low torque, or with a low, it doesn't have any primary stability. Then you can put the excised part again, and maybe you can use a glue, maybe you add a stitch, but it must be a monofilament stitch. Or if it has a good primary stability, then you can put a gingival form, or then maybe you can use the multi-units, and you can finish the torque issues and jump to the permanent phase. So, the advantages of guided surgery. The first one is the limitless touch for case planning, minimal invasive and flapless surgery. The third one is accuracy, which is the most important part for guided surgery. It's almost zero mistake. Avoiding the anatomical structures and advanced surgeries, which is very important for us in our private practice, because the patients prefer your clinic with this option because they have fears about surgery. And the fifth one, the self-retraction and short chair side, which is very important. I will show you some photos, and no need to get an assistant, no need to make any retraction. Your assistant will help you in other things, not about retraction. The sixth one is open view irrigation, the easiness of anesthesia. So I think it's about, let's open the light sorry. Let's open now. Why? Because I forget the YouTube shooting. I think it's bad, huh? In the dark area, huh? YouTube channel. Is it bad when when I'm in this situation, when it is dark, huh? Was it like this? No. The two things I'm looking for. The first thing, I want the audience to see the pictures in a good way, and I want you shooting the speech, and I don't want any problem occur in the YouTube. I didn't understand how he answered me, in a positive way and a negative way. You're always like this. Okay. So, is it good in YouTube channel? Okay, so better to close. Okay, better to close. If it is okay in the YouTube channel, then you can close. Thank you. So, the sixth one is open view, irrigation, the easiness of anesthesia. The seventh one, the atrophic crests, the easiness of narrow side usage. And the last part, depth control. It's very normal, but it is without any adapter. So, minimally invasive. This is not a guided flap surgery. I have so many surgeons, and they are so skillful. They have so many skills, and they like to open big, and they tell themselves and the others, a great surgeon opens great. A big surgeon opens big. 10 years ago or 15 years ago, when we hear this, oh, I think big surgeons do the big opening. Yeah, I think it's correct. Look, this is the picture, but no one is showing us the picture of the patient after 2 days, okay? Any other head, I mean, the patient became two-headed just for the edema, just because of the edema. This is the extractions and placing the implant and placing the impression instruments on top after the surgery, the same day, I mean, same time. Please make the comparison. This is after the flap surgery with guided surgery, okay? And the gold caps is on top. And half an hour ago, we finished the surgery. And we rinsed and make it dry and then take the picture. Again, this is just after the surgery. I placed implants and put the gingival healing abutment. You see here, when making punch out, the scalpel went in the wrong direction. But this is the only part. Okay, look at this picture very carefully. This is an M guide, and we fixated the M guide on the upper jaw. Is there any need to make a retraction? And you can work like this with your only one hand, because you don't have to use the mirror in your left hand. Look, by this way, during the operation, if the patient has some problems, you can make some more anesthesia. No need to take the guide out, and because of thanks to the open view system, you can make the irrigation. The anesthesia is very easy, and the short chair side with the self-retraction. Yes, accuracy is the most important part of guided surgery. So I have to remember one scientific paper was telling us that the deviation of guided surgery is 1.3 millimeters to 1.6 millimeters, It's about data collection. And this is a Kennedy 2 case. I mean, bilateral edentalism, okay? And I want you to see the OPG. And there is a problem with the sinus, pneumatized sinus. We have two pneumatized sinuses. And the neighboring sides, we have a lesion, and we have mobility for the number 15 and number 24. And our aim is to make the extraction and then place the implants with avoiding the sinuses. And when we match the DICOM and STL files on MSoft, and the screen is facing us. And in this screen, we can plan the implants, the number of implants, the position of the implants, the angulation of the implants, the location of fixation pins, and the sleeves is related to the flapless surgery or not. And then we can understand the posterior wall of sinus and the anterior wall of the sinus, and we can do whatever we want, okay? And after it, we create the guide. We manufacture the industrial item. So once we place the guide on the upper jaw, the most important thing is fixing the M guide in the right way. And after it, we do the punch out, as I demonstrated 2 minutes ago. These are the fixation pins. We have two options to make fixation in our kit. The first one is with the pin. We have 1, 2, and 3 over the other side. We have 3 sleeves, and we have 3 pins to make fixation. And first we drill with 300 RPM with irrigation. After it, we place the pin, and it is 1/3. It is 1/3 fixated. And we have 2 more sleeves, 2 more fixation sleeves, and we do one by one. So after placing 3 fixation pins, it's entirely fixated. And after it, we make the punch out, as you see in the video, in the movie, and we can use it, this punch out instrument, between 25 and 65 RPM with irrigation, please. And again, we have a bone mill, we have some bone irregularities on the surface of the bone, and we have to make the surface smooth. We have to flatten the surface. And after it, we will place the implant. So think of the extraction sockets, just like the ice cream cone, okay? And when you place the drill, the shoulders of the drill of the tube will touch the inner parts of the extraction socket. So it is very important for us to make the implant placement surface flatten. So tissue punch for maximum 25 RPM, 25 to 65, it is written wrongly. And this is the bone mill. Look, my dear friends, we want to place the implant here, but there is an irregular and inconvenient surface here. First of all, we have to, normally in freehand surgery, we open it and carve and flatten the side and then place the implant. And this way, how do we do? Look. The new guide system, Panasonic. So the last thing I was telling you about the bone-based implants, but in this procedure, no need to open, just make the excision, and after it, let's use the bone mill, and we go down and take it out, and the surface is ready to place the implant. Where's my friend? I think he was, okay. I just waited for you. You want me to go on? Okay. So, the second fixation instrument, when we make the first drill, when we make the first osteotomy, it's around 6 millimeters in depth. And after making the osteotomy, we can use a screw which we call socket anchorage fixation instrument. And in the osteotomy socket, if you place it, and if you turn the screw, and then sometimes we need more fixation in the bone, especially in the edentulous, not with the tooth, edentulous sides. We use this alternative method to fixate the guide. And by this, we know where to stop. It works. Okay, I can start? Sometimes it happens. Yes, it's okay. So let's continue. I hope the electricity voltage will help me, will let me finish my presentation. This is the second way of fixating the guide to the upper or lower jaw, especially in edentulous cases. The second and the third fixation alternatives are so important. Look, we make the fixation pins, and after it we made the osteotomy, and we open the socket, the fresh socket, and we made the fixation with the number 2 instrument. And now we place the implant, and if it is healthy with the primary stability, we can get fixation from the placed implant. This is what we call implant anchorage fixation instrument. Look, let's watch it. You see, the trauma is this, okay? We 1, 2, 3. Okay, I use the bone mill here. I made the excision. I use the bone mill, and with this one, I get the socket anchorage. You see it, and I never quit the anchorage because I want accuracy. When I want to place an implant, I think of an axis that we call fulcrum for the prosthetics. And I never quit the stability for the guide. And I place the first drill, and after the first drill, I can use the socket anchorage. And now I make the osteotomy. I continue on the osteotomy, and I made the implant placement. After it, I get the anchorage from implants. 3 anchorages: fixation pins, socket anchorage, and implant placed anchorage. Look, so watch me just saying bye-bye to the posterior wall of the sinus, and I will show you later. And you can close your eyes. Don't close, but you can close your eyes. Because if you close or not, the guide will do everything. Okay? The most important thing, before the sleeve, don't start the engine. Just be in the sleeve. After being in the sleeve, please start the engine and use the handpiece. So, once it is done, look, my friends, this was the plan, okay? This was the plan. There was a very big sinus here. Here you see the sinus. Here you cannot see the sinus, okay? I placed one implant here, one implant here. You see, this is the diagram on MSoft, thanks to MSoft. Look now, I placed the implants. Job done as planned by MSoft. You see, this part, this part, this part, this part. Look, I'm dealing with surgery. I'm doing so many sinus lifts, okay? But in this case, it is almost impossible to make augmentation in the sinus lift area. Why? Because I think there are no recipient sites to bone, to having some bone integrated there. And the implants you see, they're like Indian or Turkish soldiers, doesn't matter. So the case was like this, and then we placed the implants at the same day, and it's not about aesthetics, it's about function, but I've placed everything in a good way and finished this way. The initial point and the final point. Normally, to having pneumatized sinuses, it was almost impossible for a dentist to place the implants in bilaterally. So, if accuracy matters, sure. So, she came to my clinic. She was 52 years old and a heavy smoker, okay, and a poor hygiene. And she wanted me to clean her teeth. But I told her that you have chronic adult periodontitis, so we have to overcome this problem first. But after getting the radiologic examination, I changed my word, and it was almost impossible for us to save the teeth. They are hopeless teeth, because there was an epithelial attachment loss and bleeding on probing, and the mobility was 3 to 4. So, you know, my dear friend, in this case sometimes extraction is the most correct way to achieve our goal. So the 26 and 27 were previously treated with implant supported screw retained PFM crowns. And radiologic evaluation, you see the serious horizontal bone resorption and pneumatized sinuses. And our treatment plan was extracting the teeth from 15 to 25, placing 6 V3 dense plate Sirona MIS implants, which you can find in the market in Turkey. You have to remove the teeth very gently. And occlusal evaluation, the facts were evaluated. Digital model was created and STL files were obtained by extraoral scanning. And our CBCT evaluation, CBCT was taken to make diagnosis and to extract the DICOM files to be uploaded to MSoft. And digitalization, this is what we call the matchmaking. You know, there was a book, Matchmaker. Matching the DICOM and STL files, considering the bone quantity, prosthetically driven implants were digitally planned and placed virtually. Not really. So, thanks to the 3D printer, we manufacture and we produce our M-Guide, and in the operation day, first 2 pills of amoxicillin, 1 gram each, then have a good breakfast. Please do the surgeries in the very early morning. Don't leave it in the afternoon. And traumatic extractions were made and granulation tissue was removed with excisional moves to eliminate the risk of residual infection. Look, this is a guide system, but the guide system doesn't change the biology. So we have to be very careful about making the extractions. The extractions must be very atraumatically, and after making the extractions, we have to clean the inner parts, especially the tips of the socket, very carefully. Maybe you're going to do it maybe 15 minutes, okay? Let's see the real redness of the blood, okay? It is a little bit different. So if you lose a granulation, if you leave a granulation tissue, doesn't matter if you place the implant with Tesla, with M-Guide, with IOS, okay? Doesn't matter. Biology wins, and if we leave a granulation tissue in the inner parts of the extraction socket, we will fail. So don't pass through the other step before cleaning the inner parts. So let's fix the guide. After fixing the guide with pins, extra anchorage can be done by socket anchorage and implant anchorage. We did this way. And 6 MIS V3 implants were placed with multi-unit abutments, one abutment, one time concept at the same time, because we get the primary stability over than 45 or 50. And that means that we can entirely place the multi-unit abutments at the same time with the operation. The emergent profiles and parallelism were verified once again. It is very important. The selection of 670 articles, and ICQ has a nonlinear correlation to micromobility. Micromobility decreases bigger than 50% from 60 to 7 ICQ. And this is the technical explanation. And if we see the ICQ values between 65 and 7, that means that we can do the immediate loading. So what did we do? And we see the lowest ICQ value after placing the implants were between 68 and 78. So that means it was quite good to place, to go on and make an immediate prosthesis. And it's critical to make sure that the multi-unit abutments were entirely seated, which is very, very important, because we use the conical connection, and when we place the multi-unit abutment, if you see that, if you hear the voice from the bone, if you hear the voice, it comes from the bone, that means we have to make some bone profiling for the multi-unit abutment. And once perfect seating is observed, they're ready to be torqued with 30 Newton centimeter. Using a bone profiler kit, Dentsply Sirona bone profiler kit had a crucial effect for seating multi-unit abutments easily when placing the angulated abutment. Think, there is a bone and you place an implant tilted, okay? Tilted. And once it's finished, look, we have two parts of the shoulders, okay? One is embedded, the other one is a little bit higher than the bone level. So we place implant a little bit more. The left side is okay, but the right side is embedded so much, so we cannot place the multi-unit abutment. So in that cases, we use some bone profilers. The bone profiler doesn't affect the implant in a bad way, but condition the peripheral size of the implant very easily. And thanks to the unique final drill of MIS implants, the autogenous bone was harvested easily, as fresh as it could be. In MIS system, you have a final drill with the lowest RPMs, with closing the irrigation. When you use the final drill at the end, you can collect this amount of bone, autogeneous bone, and it is very, very, very effective for our rest of the surgery. And after multi-unit abutments were torqued, the sockets were autogeneously augmented, and the implants were ready to be loaded immediately. So we place this harvested bone here, here, here. In the first layer, we use autogeneous bone, and on top of this layer, we use some artificial bone graft materials. And this is unique for density Sirona MIS. Look, in this era, we don't place the implants in the bone level. We place the implants subcrestally, around 1.5 or 2 millimeters. Think that you place the implant subcrestally. It is sometimes impossible to reach the inner parts because there is an obstacle around the implant that we call bone, okay? So we have to adjust the bone like a tulip shape, okay? Like a tulip shape. So we do it with these bone profilers. Put this part into the implant, and we use this part. And it never touches the implant, but it touches and condition the surrounding surfaces. And this is the final drill that you can find in every MIS, dense place Sirona MIS implants. And if you use it as a final drill, then you can have the chance to collect so much autogeneous bone as fresh as it could be. So after it, sometimes you get the impression digitally, sometimes you use the open tray method, sometimes you use the closed tray method, and there are some scientific papers, and if the number of implants are over than 4, then please use the open tray method. Sometimes we use the closed tray method. So an open tray impression was made to locate exact implant access holes over the acrylic denture to facilitate immediate delivery. And I want you to have a look at the right picture. Who can remember this immediate prosthesis? This was the diagnostic wax-up. First, we try to finalize the picture. Once we liked everything, once we said yes, then if the patient wants me to do a temporary denture, then I'm going to use it. The temporary immediate metal reinforced PMMA prosthesis had been produced prior to surgery. I mean, it was ready prior to the surgery. Only the holes were opened after the surgery. The prosthesis was adjusted to free rotation temporary cylinders. Free rotation temporary cylinders. These are the temporary abutments. So the temporary prosthesis was fixed on the upper jaw immediately. You see the occlusal view, you see the front view, and at the end of the surgery day, we didn't wait. We prepared everything in advance prior to the surgery. After the surgery, we only get the impression and a precise impression, and then we make the impression, the stone model, to the prosthesis meet, then finalize at the end of the surgery day. So this is the initial situation. This is the temporary prosthesis. Be careful about number 21. We did it by copying everything. As you can easily see, the number 21 is a little bit low, the corner. Number 21 is a little bit low. It's the same. Why? Because we made the copies and never be away from the copies. We followed the pathway. So we waited for 4 months. After 4 months, it was done by one time, one abutment concept. Look, when we placed the implant, I met a lady who placed 2 or 3 implants, and was she here? Is she here now? No? Okay. When you place an implant, if the primary stability is not in the way that you like, and you use a cover screw and close the soft tissue, okay? When the primary stability is over than 40, then you put a gingiva healing abutment and close 50%. Sometimes the primary stability is over than maybe 60 or 55, then we can go and finish all the prosthesis in one session. After 4 months, the surgery, it is ready for the final operation, and this is the day 0. Maybe you can see the empty spaces, but I'm not sure because of the lights. Here, extraction sockets, and day 120, that means 4 months later, notice the bone volume gain around the neck of the implants. Why? Because we placed the implants subcrestally and we left no infection behind us. So, this is before surgery and this is after surgery. This is before, this is after, and this is the final metal, porcelain fused metal, and we finish this way. It's quite good. So, minimally invasive flapless surgery. I mean, we have some sinus pneumatize and we want to avoid the bigger surgeries. Then we want to do a simple case, and the patient came to my clinic with this. Doctor, I have a prosthesis. I don't want to change it because I don't have so much money, but I want you to fix my prosthesis in my mouth. Normally, it's not so easy, but let's show what I did in this case. He was a dentist. He was the teacher of my daughter, bigger daughter, and I'm so grateful for him. So, you see the front walls of the sinuses. This is the working area, okay? No chance to go back, no chance to go posterior. So we should place implants there, and our aim is to finalize the former dentures with the new implants. So we put every data on MSoft, and we try to play with the game. And for example, we place an implant, then we didn't like it, we changed the position, we changed the angulation, we changed the depth, we changed the diameter, we changed the length, we changed everything. And in the right side, you can see the occlusal view, I mean, from the top. We want to go to the sinus as we can do, but not to be in the sinus. I mean, not to go in the sinus. But we have to create a space, so we have to be, as we can do, as far as we can do to the posterior side, and there's sinus, so we cannot go. So we have to start planning with this side, okay? And if it is not enough, then we will start making the inclination. Look, we inclinate to 30 degrees, and we know that using an angulated abutment with 30 units, 30 degrees, everything will be over and we can solve the problem. So, the guide is ready. You know the procedures, DICOM files, STL files, MSoft, and planning, and then 3D printer, and here is the guide. And the first step, we fixed. Look, my friends, I want to tell everything. These are fixation pins, fixation, fixation. This is the first fixation item. You know, we have 2 more. Once you make the first drill, then you can make the anchorage from the first drill. Okay, this is what we call socket anchorage. And after once we place the implant, we can get the anchorage from the implant. So we have 3. Please don't pass over these items. It's very important. Look, this is a socket anchorage instrument. And later I will show you an implant anchorage. So this is the guide. We make the punching out and then take the guide out. And you see these are the trauma. This is the trauma, the only trauma. And then the third part, we made the excisions and put the guide again, fix in the same way, which is very easy, and then place the implants. And this is just after the surgery. No bleeding, no stitches, okay? Because with the technology, you know where to place the implants, and you're sure. If you get the data very properly, in a correct way, without not stepping any other step, okay? Passing any other step, then everything is all right for you. Placing the implants and multi-unit abutments on top, okay? Once we put the multi-unit abutments and if we observe that the multi-unit abutment is fully seated, please torque it with 30 Newton and don't touch it again. If you don't touch, you will find a very, very, very beautiful gingiva with keratinized surrounding places, and you will like it. This is what we call one abutment concept. Otherwise, we place implant, we close, we open the cover screw and take it out, and put a gingiva healing abutment, then close again, the second stitch, okay? And wait for 10 days or 15 days, then open again, then put the impression material inside, okay, impression coping, and get the impression and create the model, and etc. In this method, if you if you feel satisfied with the primary stability, then let's better place the multi-unit abutments once you can see the fully seatment. The implants, okay. The implants were placed as if we planned an M-Soft, and you see we wanted to go as far as we can go posteriorly, but we didn't touch the sinus, the front walls, and look carefully. This is the M-Soft view, and look, one implant here, one implant in 21, one implant here, one implant here, one implant here, and one implant here. You see the angulation, just watch. The same. And look, I didn't make any prosthesis. This prosthesis is my patient's former prosthesis. I only made implants, okay? But I made the scanning. I think Pratik will show you, okay? I made the scanning. I get the picture with all views, and after it, I could do everything. So the teacher went good. Yes, this is an atrophic crest, and again, avoiding the advanced surgeries. We're not dealing with the sinuses only. We deal with the atrophic sites in the lower jaw. Sometimes it's almost impossible to place implants. Yes, it seems like impossible, but you see the triangular shape. That means when you make the peak of the triangular shape, sometimes we can make it flatten and then place an implant. This is what we call bone reduction. And you can do the bone reduction with guides, but this is not our topic now. So you see here, there is a very, very, very big bone deficit, bone loss. And the patient is going to a dentist, another dentist, another, no, we cannot do, no, we cannot do. And when she came to me, yes, I think I cannot do, but let's evaluate the radiologic X-ray, the radiologic data. So, the patient has one tooth, number 16, okay? And it doesn't have any strategic importance for us. But what did we do? First, we get the tomography, CBCT, okay? And see the situation is very, very, very difficult, nowhere to place implants. And you will see this is the implant area, the only area, okay? Hard case. And the other thing, the cross-sectional views, you can easily see that it's almost impossible to place implants from the lower jaw. Why? Because it's it's worse than the triangular shape. You see how we can do. In this point, we have to choose the right points and the right angulation and the correct width of the implant. So, one of my colleagues asked me, in the edentulous cases, what do we do to get the DICOM files? She was sitting here, but I think she has to do something. And sometimes we have some reference points. In atrophic crest protocol, we create the wax-up model, and after wax-up model, after having the wax-up model, and we place a medium body, the impression material inside, and put it in the mouth. We have to be quick a little, and then close in the centric relation and get the tomographic X-ray. If it is edentulous. If it is atrophic, edentulous. I mean, if it is edentulous, it'll be good. If it's atrophic, edentulous case, it is very, very, it's crucial. So, look, when you get the CBCT with this way, at the same time, so you hear, it's easy for us to distinguish, to separate the bone and the impression material, and we can understand the borders. We can understand where the bone starts, where the bone finishes. It is very important for us to make the plans of implant placements. And after it, in AmSoft, we started the game, okay? We decide to find the number of implants and the locations, see the angulation, they're parallel, which is very important in this case. Sometimes it's not, but sometimes it is very important. And think that if you use a freehand surgery, it is almost impossible to do this. You can do it once, but you can never do it 99 times. So guided surgery is superior to freehand surgery in all disciplines. So once it is over, once the planning is over, what do? We create a drone-like M-guide. This is something weird, I know it, but this is for the patient. In the guide, we cannot use it in the other mouth. So it is a little bit weird, I know it. This is the upper side, this was the lower side. You see the bridge, see the sleeves, fixation pin hole, fixation pin hole, fixation pin hole, implant sleeve, implant sleeve, implant sleeve. And there are the bridges and clamps here, clamp here. Okay. So we finished the surgery. This is a minimally invasive, no bleeding, no stitches, no cut, no incision, okay? No edema, no pain. The patient is looking for this, always. But later, let's evaluate this with the keratinized tissue. Maybe we can improve the keratinized tissue quality and quantity. But it's not the issue now. So, look, you see the implants, everything went good, everything was as planned. But who can answer? Why do we keep this tooth in mouth? Yes, doctor. You look so smart. So why do we keep it? Not a difficult. Not difficult. You can talk like this. Sorry. No. Outside. Sorry. Thank you, sir. To get the reference, because we don't want to lose the reference. It is. That doesn't mean that it's better than he's better than you. Okay. He trolled and it was quite good. Okay, no problem. And later he walks like this. Yeah. It's not important. So, when do we keep in mouth? We like matchmaking, okay? In Turkey, we have so many matchmakers. The mothers, okay? Hey, young boy, I have a daughter. Like that in India? I don't know. Is it the same? The same, okay. For example, when you want to marry a girl, okay, here your mother wants to say yes before everything. Is it like this here? Is it tradition like this? Okay. Yes or no? Yes, okay. So, DICOM and STL, wedding ceremony, matching, and after it, everything is okay. With this natural, immobile tooth, we can have the reference, and we can make the DICOM and STL files matched so easily. Sometimes we put some titanium pins inside the mouth, and we try to match. Sometimes we do some guttapercha. You know guttapercha? You use in endodonty? Perfect. Sometimes we we dig holes and put some guttaperchas because why? In the tomography or in the OPG, we can see it clearly. Sometimes we put some metal balls. Okay. Oh, what happened? Okay. So, why do we keep it? DICOM and STL file, matching. Yes. Now, once everything is done, we made the metal rehearse. And in this rehearse, we made the vertical height. We find the vertical height by making some, the common things, common issues. And then we finalize it with the acrylic porcelain, acrylic denture. Why? Because we have a very, very big soft tissue deficit, okay? And hard tissue and soft tissue. It's almost impossible for us to tolerate the missing parts with porcelain crowns. So here, since we place only 4 implants per jaw, and since we have a very big deficit about hard and soft tissue, then we have to finalize it with an acrylic denture. So, yes, the case is finished in this way. Raising the flap or without, if you don't want to make the root there, okay? And we don't want to see the root, okay? So then do not open the flap. Sometimes we have insufficient attached gingiva for periodontologists. It's very important. So that time, maybe we can open and then close. Maybe we can make the excision and then place again. So direct sinus lifting is very important. If you want to do that, then why not why not raising the flap? So what I did in the right side with raising the flap, with the left side without raising the flap, only making the punch-out excision. So let's do it. In the right side, we have late immediate protocol and indirect sinus lift with some augmentation, bone augmentation, And for the lower side, or for the left side, I'm sorry, the only thing for us is the crest centering, screw channel emergence, angulation. This is the most important part. So for the upper right side, we made the extraction, and this is a late immediate protocol. And after extraction, if you wait for 2 or 3 weeks for the soft tissue healing, this is what we call late immediate protocol. And what we did, first, we went and create the model, and we made the implant simulation, and then we made the design of M-guide, and we fixed the M-guide, and we did our job. For the right upper side, we raised the flap and cleaned the granulation site, make the indirect sinus lift, place the implant, and covered everything with a membrane, and fixed the membrane, and closed primarily. This is a monofilament suture from Dosan Turkish company, as I told you before. For the left side, we didn't raise the flap. We only make the excisions, and we made punch outs. And after punch outs, we placed the implants, 2 in the right side and 3 in the left side. You see no difference with the raising the flap or without raising the flap. So we finished it with the occlusal screws, and then on top of the occlusal screws, we placed some composites to cover the screws on top. This is the 4th year. Avoiding the anatomical structures again. Yes, with the M-Soft, we may have the chance to make diagnosis, not only placing the implants. We can we can understand where the nervus alveolaris inferior, and sometimes we can face the infections, which is very important for us. And when we open, we make a plan to clean the infection first and then place the implant. It is very important. And after it, the patient came to my clinic in this way, and she's a little bit of fat and young, old lady, and she has problems about type 2 diabetes. And we had a very big cooperation problem, and I was not sure about his post-operative oral hygiene, but I tried my chance, told her everything about the maintenance phase, which is very important for us. And you see an infection, 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 and the cracks, total clearance case. We call it total clearance case. Then we create the model, and we became the model as if we had made the extractions in the mouth, but we didn't. We did it artificially, but kindly, but gently. And then plan the implant placement, the locations, and then designing of the guide and finalizing the guide. And we fixed the guide with 3 ways. 1 with fixation, 2 with implant anchorage, socket anchorage, and the 3rd one, the implant anchorage. In this picture, you can see the implant anchorage. Here, the implant is okay, the implant is okay, the implant is okay, then we made the anchorage, okay? And after that, we put the impression coping for closed tray, and then we made the final impression, for temporary crowns, we made the final impression, and look. The implants were done as if we put something straight and just draw it. In fact, I didn't do that. The guide did the operation. I just planned. With the guide operation, we think that we are good doctors. No, the good is the good is the guide. So here we can see. May I sit a little? I'm sorry. No, only two minutes. we have some important criteria, which is a correct number of implants. The second one, correct positioning of implants. The third one, correct angulation of implants, parallelism, and correct emergence angulation of screw channels. And we had a conversation with my colleague, and I think she was asking me about the parallelism and the correct angulation of implants, correct emergence angulation of screw channels. And I answered, it depends. It depends on the case. So let's watch it. Crowns with cemented abutment support or bridge, ball attachment and locators supported over the denture, then parallelism is very important. Crowns with multi-unit abutment support bridge, advanced surgeries on atrophic crests, then correct emergence angulation of screw channels is very important. So this is the initial part. This is the final part. You see the occlusal view with occlusally screwed. You see number 11, 12, and 13, and 21, 22, and 23. We're going to finish it. Okay. So the 21, 22, and 23, okay? And this is the final. Initial part and the final part. And sometimes we need to increase the soft tissue volume on missing sides. This is number 12. And there was an endodontic failure, and then we had to extract this tooth. And here we need a bulky soft tissue, so we need to do something. So we just planned M-Soft. We just planned the implant with M-Soft. And this is an extraction socket. And you know, in the extraction sockets, we don't have to, we must not touch the bone buccal plate, which is very important for us. And we produce the guide, and we place the guide. Here I have a question. Another smart man I'm looking for. I'm looking to you. No. Yes, again. Do we always need to perform punch-out excision? No, it is okay. Why? Do we always need to perform punch-out excision? We do this way. Look, with a diamond burr, before the surgery, after making the anesthesia, we make de-epithelialization, okay? We made the de-epithelialization. We didn't make any incision, okay? We made the de-epithelialization, which is very important. Why? Because in the soft tissue healing procedure, with the epithelium to epithelium, nothing is going to happen. With the connective tissue to connective tissue, everything will be okay. So we made the bleeding and the epithelialization. After it, we made the incision a little bit palatally, okay? And first, we have to do it full thickness, and we get the bone touch. It is very important. Normally, I use the 15 for the operations. And we made the sulcular incision. You see it. And then, look, what did we do? First de-epithelize, and then making the incision, and then raising the flap, starting with full thickness, and then split thickness in the buccal side. And we create a space, okay? And now we will make it curling in like t-shirt inside, okay? Curl and in. Okay, so we just give a break. Okay, come on. So in 1 minute, I'm going to finish. Okay? 5 minutes, I'm going to finish for a break. Okay. Okay. So we see in 2 or 3 minutes, you're going to make a break again, and then we'll turn back. The order is big, okay? And then we make curling inside, and we create a thick, bulky gingiva. And then you can close this one, the last one. Yes. And securing connective tissue and fixing it with a monofilament and 5-0 or 6-0. I think 4 or 5, I'm sorry. And suturing the connective tissue. Then what did we do? We placed and stabilized the guide and then make the osteotomy starting from the first drill of 6 millimeters and the others 10 millimeters, 11.5. And check, first we have to check the M guide, then we have to make drilling. And once we place the implant, go and stop. And the last two or three circles, screws. Okay. Then I made a final moves with a hand ratchet, feeling the latest torque, final torquing, and once it is placed in the extraction socket, around 4 millimeters subcrystally, which is a very scientific number to place the implant subcrystally, it is ready for the digital impression, which is very, very important. And now we made the scanning, okay, with this machine, but this is only scanning. Now here we don't have any milling machine. Look, we look everything, the right side, the left side, the buccal side, the palatal side, everything, the material, the shape, and the color. And we have the machine, we have some cubes, okay, and put it in the milling machine, and after 16 minutes, everything is over for 1 crown. Then we finalize the temporary and send the patient. So, another case, but I think I have to give a break, and let me tell you how many slides after these. Oh, so many slides. No, no. It's around 35 slides. Are you sure that maybe I can finish it, or the chairman is waiting, so I'm going to close it. Okay. So a break. They want a break, and after the break, so we will do it again. So can we please give the time, because the most important part is after these.
We will be having now break for an hour, and later intraoral scanner demonstration and its relation with the CBCT will be done.
Okay.
And the even question answer session will be done over that time only.
Okay. 1 hour later.
Yes, sir.
So this is now half past 2. 2:30. Okay. And 3:30. Huh? Okay. 3:30. I'll be here to finalize the lecture. Okay. Okay. I'm called from the directory, so I had to go, and better to finish the presentation. And now I think the last case, or the last two cases, I'm going to introduce you a happy man with poor hygiene, and he has so many problems, but he is smiling all the time, but he doesn't care about anything. In this case, we try not to place any implants if he is a heavy smoker and if he doesn't care about the oral hygiene procedures. And but this patient came to my clinic, and he promised me to do his best after the rest of after the operation. I mean, the rest of his life. And then we started evaluating the patient. And as you see, we have a very, very, I'm sorry, doesn't stop, doesn't work. Okay. So, as you can easily see from the OPG, there is a very severe bone loss, and there are so many mobile teeth inside the mouth, and generally the patients are coming to our clinic, and they want everything in the same session, the same appointment. I mean, they want us to make the extractions and place the implants at the same time, but they do not care about the lesions, they do not care about the infections, they do not care about the wax up, the planning, so many things. In that situation, I plan not to do any advanced surgical operations to the patients. What I do, first of all, I made the extractions and clear all the infection, and after it, I want to have the teeth don't have any mobility, okay? And I want only the stable things in the mouth. And by this way, I clean every infection, and I passed over the mobility problem, and then I did something to my patient, which he can put in and take it out, and I thought that it'll be easy for me to make him understand the importance of the teeth, and if it is not stable, if it is mobile, it'll be very difficult for a patient for the rest of his life, because he was so young, but he was still happy. He doesn't care about anything. And after it, we made the evaluation of radiology, and having the DACOM data and getting some STL files from the intraoral scanning. Then we match it on MSoft and start planning with the implant positions. We're going to place 4 implants, and we're going to make a bridge, and we want to use some regular multi-unit abutments and some angulated multi-unit abutments, and then we try to fix a temporary PMMA for immediate prosthesis, and after waiting for 3 months or months, then we're going to finalize the case with a stable, with a permanent prosthesis. So we create a customized guide for this patient. We have a very big advantage for making this guide. Is there anyone to tell me what the advantage is? The same guy. Eyes on you. You're 2-0. So answer me, please. There are so many teeth in the mouth, so we have so many reference points. So it is very, very easy for us to create a customized M-guide, and when we had the M-guide, it is easy for us to adjust on the teeth. So many clamps, so many bridges, so many reference points. That's the thing we are looking for. So on the operation day, we first fixed the guide. No need to make fixation pins because we had so many teeth, but I want to do it in a certain way. So I made my fixation pin. I put my fixation pin at the same time. And first of all, I made the guide stable with the fixation pin and stable with the socket fixation instrument. And plus, I made the operation. I placed the four implants at the same time. It's around 15 minutes or 20 minutes because it is guided, fully guided. Then take the guide out. And what did we do? We placed the implants and no bleeding, and we finished the operation. And now it's time to start evaluating the radiologic views. You see 4 implants here, and the cross-sectional views. We are in the bone in the right position, here for this one, here for this one, and here for this one, and here for this one. You can see the abutment, which is angulated around 17 degrees. This is straight one, this is straight one, straight connection, conical connection, straight conical connection, but here, angulated abutment. So 1 tilted plus 1 angulated means a straight structure. And after it, we put the impression copings on top of the multi-unit abutments, and we place 2 implants, the multi-unit abutments, and temporary cylinders as a temporary abutments, which is made of titanium. Then place the PMMA temporary crowns on top, and it was like this. And after the operation day, it became this way. And finally, we tried to find the best color, which must not be white all the time. If it is a little bit brown, then we have to act like brown. So we finalize it with porcelain fused metal and having some pink porcelain to tolerate the missing soft tissue parts. So the job done as planned. He was happy again. He was happy. He's happy. He will be happy. He like to be happy. And it's all right. Yes, sometimes in our clinics, the patient comes to our clinic with high expectations, and we have to be so careful about this. And prior to surgery, prior to the procedures, we have to talk every issues, and we have to make a contract, maybe. What are you looking for? What I can give it instead of this. So this lady had high expectations and came to my clinic and wanted me to place an implants. Why? Because she had an accident. She crashed to the wall, with the glass, and when she was going to gym, and she faced a very big problem. But when I first saw her in the clinic, I was interested on the lips, and the lips didn't seem normal and regular lip, and I think there is some material on the lip. So it is very important to seize everything, to see everything, to feel what patient is going to look for, and the attitudes. So we have to be very careful about the attitudes to the doctors. So you see the crack, and she bumped his head to the glass, and this was a zirconia bridge, and zirconia crowns have a very big disadvantage about chipping and cracking. Then the lady faced this kind of problem, and we made the evaluation, the panoramic X-ray, and we had 6 unrestorable hopeless teeth, but 2 they can be restorable, but they had a strategic problem, obstacle for us. So for the other 6 teeth, no need to get any permission. But the other 2 teeth, we had to have the permission from the patient. Why? Because they were healthy. And we have to respect the decisions of the patient. So we have to act in this manner in our clinics. So she said yes, and then we decided to make a total clearance, total extractions. And before this, we get the impression. And after getting the impression, we get the stone model. And when we handle the stone model, we carve. We've removed the teeth from the stone model as if we had extracted in the clinic. Okay? But we have to be very gentle. We have to be very precise. Yes, it may not be definitely precise operation, but we have to think. We have to act. We have to think before we perform. So gently, gently, and after that, we made a wax-up model, which we can use if the patient wants us to do that, to perform that. We made a wax-up model. It is made of normal plastic feet, and this is just for making the diagnosis. And after it, we get the X-ray, we get the data from the DICOM data. I mean, we get some ideas from the DICOM data, and then we did something. I made the diagnostic wax-up prosthesis and scanned it again and match it with the initial scanning. And I saw that it is a little bit in the retrusive side, okay? And the patient has a very big lip, and if I align the teeth like that, I'm going to face a very big problem. The implants will be healthy, but the patient will not be happy. So what I did, no problem with the alignment, but an invitation to lip collapsing. So the green one are the initial point. The blue ones are the ones that I align after artificial removing of teeth from the stone model. Okay? So what I did, I pushed the teeth more buccally and tried to catch the new position for standing the lips, for holding the lips in a proper way. So then decide where to place the implants, and then decide the abutment types, the straight ones and the angulated ones, and the heights, everything. And then we start designing the guide. At last, we came to the surgery day. We did the extractions very, very kindly and in a not traumatic way. And after the extractions, we clean the inner parts of the socket very deeply. And it is very important than everything. Then we placed 8 implants in the extraction sockets. And as you can easily remember, there is a unique instrument coming from the implant, the product box. It is a final drill. And when you use it without rinsing, then you can harvest an autogenous bone. And we can put it here, the extraction sockets. And once it's done, we place the implants, and one tilted implants, and the others are straight. And about tilted implants, what I can say, if you place an angulated abutment, if it is not more than 25 degrees, it's okay. If the implant is healthy, if you help the implant also integrate it to the bone, then no problem will occur. But the thing is that you have to adjust the neck of the implant here in the bone. So we use a bone profiling method for this bone reduction, okay? Selective bone reduction. In this part, we made a bone reduction, and the other part, we did no reduction of bone. And one tilted And again, one tilted abutment, then it comes straight, like this. And the structure can hold the whole system well. So if you had problems about placing straight implants due to having pneumatized sinuses or the lack of bone, etc., then you can choose, if it is not over than 25 degrees, the tilted angulated abutment. And that means more implant bone contact, eliminating the unexpected bone augmentation procedures and avoiding the anatomical structures, biomechanically superior over cantilever units. I don't know what to say about it, but this is a scientific paper, so I've placed it here. And more stability in minimum bone volume. Look, sometimes we can place only 6 millimeters or 8 millimeters implant if it is straight. If you tilt it a little bit, then you can place a 13 millimeter implant. If it will be healthy, then please choose the tilted implant. But if you use more than 30 degrees, an angulation of 30 degrees, let's not use it. It's a waste of time. So at the operation day 0, when we finish the stitches, when we finish the operation, you know, we had a diagnostic model, and we made, we sent it to the technician to put it in the oven and get the temporary prosthesis, and we fixed it at the same day. Okay? And this is 5 days after the surgery. Everything went well. We were so lucky. The plan was good. The patient was good. I performed good. And at the end, it was so nice. And you see this picture, 4 months later, it became like this. And be careful, and it becomes pink. The pink is the color that the periodontologist loves so much. Okay, it had happened in day 120. That means 4 months later. 4 months later, nothing. I mean, in the 4 months, I did nothing. Okay, just made the sides stable. Okay, and left them in a secondary healing process, and put the immediate temporary prosthesis on top, and I did nothing. And the biology worked, and now a very good view. At the end, depending on your wish, if you want us to do the zirconium crowns, that we have some extra instruments named cementing cap for multi-unit abutments. On top of multi-unit abutments, we place them and screw them, and it has a different kind of texture. Then you can find, I mean, you can improve the surface to stick to zirconia crowns. And 2 views for the anterior position and the occlusal position. The patient was happy. Maybe you can see the white composite fillings here. They are the holes. Whenever she wants, it'll take only 5 or 10 minutes to take the prosthesis out. I will remove the composites and then find the screw and then turn it back. Then I can take it out and do something else. Do any fixation. So she came to my clinic like this way, and I finished with this way. Yeah, I have some warnings, and it is very important. The most important thing, if you had a mobile teeth in the mouth, it is almost impossible to create a guide. Why? Because you cannot take the impression. If you do a physical impression, think. You get the volume in the spoon and get the impression, and the mobile teeth moves. Okay? And in the stone model, you see the tooth not in this position, you see it in this position. Then it is a very bad thing to finalize the M-guide system, and you cannot feel the right place to place the implant. The other thing, the limited opening of mouth. Normally, if a patient comes to our clinic and he had a problem about limited opening, then sometimes we want to place an implant. We start with angulated a little, and then after digging a big hole, then we make it straight, okay? This can be done by experience. Don't try this. But in this guide system, you cannot go there and you cannot enter the sleeve perpendicularly. So it's a big problem. And when you first look at the patient, if he or she cannot open his mouth more than 2 fingers or 2.5 fingers, then no way. Please don't use the guided surgery. Cases with tooth extraction. You know, in the model, we remove the teeth as if we had extracted. But it's not the same. Normally, it's not the same. So you have to be very gentle. And if you didn't do any guide procedures, maybe at least 20 times or 25 times, do not use it. Why? Because it's about estimating something. M-guide system doesn't like estimations. The system likes the precision. So I feel a little bit experienced about the guide system. So the problems that I can face, I can estimate prior to the surgery. That's why I do this, okay? And the other thing, atrophic crests. To have the reference point, very important. So you should use the impression material, or you should use some gutta-percas on the wax-up model, okay? And what else? You can place a titanium pin in the bone and then get the X-ray. So you must be very careful. The most important, the best way to achieve our goal about taking the data, the DICOM data, is, I think, using impression material inside the wax-up model. The data calibration, you know, porcelain fused metal, when we put the head on the machine and we have some artifacts on the X-ray due to having metal inside the porcelain. So sometimes we have to renew it, take it off, remove it, and make a PMMA, then put the head in the machine. So data calibration is very important. And the last, but not the least one, the absence of M-guide philosophy, as I told in the first part. Exhibiting the final picture, deduction, coming from the end, starting from the end, having a plan. This is about the philosophy of M-guide system. If you don't like the system, I have so many friends, don't like to wait, don't like to work, don't like to study, then no need to use M-guide system for those. Another point, using M-guide doesn't guarantee your implant to be osseointegrated. I mean, for which reason you lose an implant in a conventional method, in a freehand surgery, you have the same possibility to lose the implant in the same way. For example, if you lose an implant due to having an infection, you may face the same problem. So you cannot tell me this. I used the M-guide, okay, you did your best, perfect, okay, but I lost my implant. Yes, you can. I lost implants also. So it is very, very normal. But science definitely guarantees that you are the winner of future. So go on looking for the information, go on looking for the data, go on looking for the innovation, and go digital, please. And after it, maybe you can lose 1, 2, 3, 4, 5, 10 implants, but you'll be the winner of the future. So when I first started using guided surgery, maybe 6 years or 7 years ago, I mean, I deal with guided surgery maybe over than 10 years, but I use M-guided system for more than 6 years, and I had so many friends. Oh, doctor, what did you bring to my life? I don't want to use guide because I want it open. I like the bone. I like the sensitivity. I like to touch the bone. I like proprioception. No need to place one implant. Okay? But in the 6 years, we did so many cases with so many patients. And now we overcome this mentality. So we have so many friends who will be the winner of future. I hope you will be in this group also. But don't think that you are in a bad situation or good situation. No matter how you are, I mean, no matter which kind of situation you are in, don't think. Just look forward, just think, and just study and just work hard. Thank you, but I didn't finish. Only 2 or 3 words. Thank you for applause. So the only take-home message, as I told you before, just start from the end and remain guided. It is very important. And after the invention of implantology, I call it Implantology 1.0. But now the era has changed. Now I call it Implantology 2.0. And I believe, maybe in 5 years, in 10 years, or I don't know when, they will send the implant with the guide. I mean, you're going to order an implant from the company, and they will send the implant with the guide. And there will be no malpractice. The only thing that we can face may be a complication, which is very, very normal. So I'm in India, and I like this leader. So be the change that you wish to see in the world. So he's telling this sentence to you, not to me. And you know Shakespeare, and he's a very great writer. And you know the sentence to be or not to be. We have Shakespeare's in dentistry. You don't know maybe, but he's dead now, Mr. Brennemark, which founded the implants. You know it. And found a rabbit in the rabbit tibia. He put an implant, titanium, in 1955. And after that, he found that something happened. Titanium was osseointegrated with the bone. Then he invited an implant. And the best sentence we can easily remember from his words, no one should have to die with their teeth in a glass of water beside their bed. You see the aphorism? A very good aphorism. In 1955. The implantology started with 1950s, okay? And my aphorism will be maybe 10 years later or 20 years later, I don't know. One day, I'm not Brennemark, okay? I'm just a boy. So all the implants will pass through this guide, and I bring my... Thank you so much. These are my teammates. And they told me to send you best wishes from Turkey. And thanks to them, because they are working in my clinic now. And if they don't work, I cannot be here. And a big applause to my team. And there is also an Instagram address. I play some cases all the time. If you want to see some cases, see some events, then you can follow the link. And my wife, I think she's watching in the link. Thank you so much. Okay. So, any questions? Any questions? You help me all the time. The question asker. Thank you. So I closed my PC. You don't have any question? Proprioception in future? Yes. Sorry, I couldn't understand the question. I'm sorry. Can you please tell me again? I'm sorry, it's my fault.
That proprioception you told na initially,
Yes.
that is we are lacking behind in relation to proprioception,
No, no, no.
in relation
Due
to
to,
MGUT.
okay, let me answer.
Uh,
Due to having an open view system, okay, it's not a closed tray-like shaped guide. So you can easily see where you are. So you can easily see everything. If any anesthesia is needed, you can perform the anesthesia by not taking the guide out. So no problem about proprioception. It's an advantage, not disadvantage. It's yes, yes.
So for it will be directly under which? Yes, sir. Totally edentulous. Totally edentulous, sir. Okay. It is not possible to fix them from buccal aspect or labial aspect like we did. Byte registration. Yeah. Thank you, sir. Yes, sir. Yes, we are.
Hello, hello.
Thank you, sir, for your precious time and the knowledge you shared with us. Now, Dr. Deepak Nagpal, sir, will felicitate Dr. Burak, sir, with the certificate and the memento. Now I request Dr. Isha ma'am for the vote of thanks.
Good evening, everyone. On behalf of Department of Oral Medicine and Radiology, it gives me immense pleasure to deliver a vote of thanks for this event. I would like to extend my heartfelt gratitude and respect for our distinguished guest speaker, Dr. Burak Hasar sir, for not only sparing their invaluable time for us to grace this occasion, but also for enlightening us with their commendable talk on the subject. Thank you, sir. We owe you a lot. It is my pleasure to thank our Honorable President, Sir, Shri Sharadji Kalmek Sir, Honorable Secretary, Shri Hemanji Kalmek Sir, for giving us this wonderful opportunity to conduct this CDE program. I would also like to thank our respected Dean Sir, Dr. Deepak Nagpal Sir, for his constant support and guidance. No event can take shape without a hardworking leader. A special thanks to our pillar of strength, Dr. Ashish Lanjekar Sir, Dr. Sathavne Sir, and all staff members of Oral Medicine Department. I would also like to thank Dr. Raksha and Dr. Priyanka for smooth conduct. I would also like to thank Dentsply Sirona, and I'm extremely thankful to the IT committee for helping us with audiovisual aids. And last but not the least, I would like to thank all the participants for their patient listening. Thank you so much, all of you.